Benign skin lesions are a very common cause for consultation. Affected individuals are wondering, are they safe, are they cancerous, or are they precancerous? Of course, there's increasing demand for treatment because a benign skin lesion may be an inconvenience. It might catch on clothing, catch on objects, or bleed, or there may be a demand for a cosmetic reason, something they'd like to get rid of from a cosmetic point of view. In this lecture, we're going to cover some of the most common benign skin lesions: epidermal and pilar cysts, benign epithelial lesions such as seborrheic warts, fibroepithelial polyps, viral warts, and benign dermal lesions such as haemangiomas, Dermatofibromas, melanocytic nevi, and lipomata. A true cyst has an epithelial lining. False cysts, such as myxoid cysts, which tend to occur on the digits, do not have an epithelial lining, and as such are not true cysts. Epidermal cysts are quite commonly incorrectly called sebaceous cysts. The lining of an epidermal cyst is epidermis, and the cyst itself contains macerated keratin and not sebum. Epidermal cysts may be solitary or multiple. Common places to find them are on the back and on the face. Pilar cysts, however, arise from hair follicle epithelial lining. They're very often multiple, commonly familial, they're dominantly inherited, and are predominantly found affecting the scalp. Epidermal cysts are usually firm and non-lobulated. They may be flesh-coloured or have a yellow-white hue. They frequently have visible in the centre a central punctum, and this may become more evident if gentle pressure is applied to the cyst. If more pressure is added, then some of the contents may be expressed from the punctum, and that is expressed is a white putty paste-like material which has a very acrid smell. Epidermal cysts tend to slowly grow over the years, and they usually do not undergo spontaneous resolution. Occasionally the cysts will rupture, and that tends to occur after the cyst has either been manipulated or traumatized, and the acrid cyst contents get into the dermis and produce an acute inflammatory reaction. And what happens then is the cyst area will become red, swollen, and tender. Occasionally epidermal cysts will become infected by pyococcal infections, but most of the acute inflammatory reactions are due to rupture rather than infection. So if an epidermal cyst becomes acutely inflamed, then the cyst ideally is drained. So local anaesthetic is put over the cyst, a scalpel blade introduced, and the contents plus pus can then be expressed. The cyst will then become very much less inflamed, the swelling go down, and then when the situation is quiescent, the remaining cyst can be excised as an elective procedure. So here's an example of an epidermal cyst on the neck, and again I think you can just see the punctum visible there. So a decision has to be made as to whether this lesion is excised or not, and this will depend on the visibility of this cyst versus the appearance of an undoubted scar. It's important to remind patients that the cyst wall of an epidermal cyst is very fragile, and if a small piece of the cyst wall remains after excision, it's likely that the cyst will recur. But there only is two treatment options, that is either leave it alone or excise it. Pilar cysts are very common. They are ultimately usually multiple. tend to occur on the scalp, but can also occasionally occur on the head and neck. They're dominantly inherited. They're firm and they often move between your fingers when they're being palpated. Unlike an epidermal cyst, they do not have a punctum. They often stretch the overlying scalp to make the hair appear thinned. Pilar cysts have a firm wall that's very easy to remove completely, and they have very low recurrence rates. Myxoid or mucus cysts are not true cysts, as we mentioned before, as they don't have an epithelial lining. They tend to occur as a translucent swelling, most commonly on the digit overlying the distal interphalangeal joint. So, as mentioned, they have this glassy, translucent appearance, and there may be a history that if the cyst is either injured or punctured, a crystal clear jelly-like substance may discharge from them. So when a myxoid cyst appears on the overlying the distal interphalangeal joint at the proximal nail fold, they quite commonly will press on the underlying nail matrix, and this tends to produce a longitudinal groove in the nail plate. Treatment of myxoid cyst is difficult. There are many approaches. They can be under sterile conditions punctured with a clean needle and the crystal clear contents expressed on a repetitive basis. And some myxoid cysts will go. One other option is to express the contents of the myxoid cyst and then treat the area with cryotherapy to try and seal the cyst. Lesions have been treated with sclerosant. So a sclerosant is injected into the sac once it's been punctured and the contents expressed. Ultimately, the cyst can be excised. So this involves local anesthesia, incising down the edges of the nail, reflecting back the proximal nail fold, and then the cyst can be identified and removed. Milia are very common small white cyst-like lesions between 1 and 3 millimeters in diameter. They are intraepidermal cysts, and they're due to little pearls of keratin arising within sweat ducts. They commonly occur around the eyes, on the forehead and chin. Occasionally they can occur after inflammatory skin conditions, particularly some blistering conditions, but more commonly after eczema. So these are very common and quite easy to deal with. The easiest way is to just introduce the beveled edge of a needle into the cyst, and when the needle is rotated, the tip can be used as a tiny little cutting device, and once the top of the cyst is incised in this way, the keratin cyst can be expressed. Seborrheic keratoses, otherwise called basal cell papillomas or seb warts, are exceedingly common and almost universal by the age of 70. They're usually multiple. Many people will develop them even in their 20s and 30s. They're rough, pigmented, and eventually become rather warty in their appearance. They start as a small papule and slowly spread to turn into plaques in size anywhere between 1 and 4 centimeters. They have a dry, dull surface which may crack rather like dried mud. Despite them being so common, the cause really is unknown. If people have got multiple lesions, then there's often a family history of multiple seborrheic warts. There are some seborrheic wart variants, so very common in African skin and also in Indians, is a condition called dermatosis papulosa nigrans. And these are tiny pigmented seborrheic keratoses that tend to occur around the eyes and on the cheeks. And here's some examples of seborrheic keratoses in close-up. Again, a dull, rough appearance, clearly marginated, often irregularly pigmented, maybe irregularly marginated. If you look carefully, you can sometimes see some little white cyst-like lesions called horn cysts. And these are pathognomonic of a seborrheic wart. They have a stuck-on appearance, rather like chewing gum that's stuck underneath a desk. So they have this typical stuck-on appearance. Seborrheic keratoses never turn malignant, but it's not uncommon for them to catch on things like waistbands, bra straps, around the hairline after combing. And when this happens, the seborrheic warts may become slightly swollen, irritable, tender, and itchy. So this is a common cause for concern. A pigmented lesion suddenly changing, and it's very reassuring sometimes to be able to tell people, oh, it's only a benign seborrheic keratosis which has become irritated, and they can be treated in that instance by general curettage. So the vast majority of seborrheic keratoses never require treatment, and people just need reassurance that they are non-cancerous and never will become cancerous. However, they can be a nuisance, particularly if they catch, and of course they can be a cosmetic nuisance, particularly on the face, around the hairline, over the upper back in women who wear backless outfits. How do we treat them? Well, thin lesions can be treated by liquid nitrogen cryotherapy. But if people have got thicker lesions, they won't go with cryo, and we tend to use a technique called curettage. Local anaesthetic is introduced underneath the seborrheic wart. The curette is scraped across the skin, and it just finds the plane between the normal skin and the seborrheic keratosis. These are then peeled off. The area underneath often oozes and can be treated then by cautery to stop the bleeding and prevent it recurring. Actinic keratoses, sometimes called solar keratoses, again are exceedingly common and increase in frequency as people age. They tend to be confined to the light exposed areas, so they're very common on the face, the back of the hands, the feet, and the lower legs. They've got a rough, sometimes a slightly sandy coloured appearance, and are very common on the bald scalp, ears, face, hands, and lower legs. And generally they feel rather rough. So here's an example of extensive actinic keratoses over the foot, which in a woman is a relatively high sun exposure site. You can see the sandy, rough scale adherent to the red areas below, and they tend to be symmetrical, occurring in a very similar distribution left and right. So in the upper photograph we can see quite extensive actinic keratoses over the forehead and bald scalp, and we sometimes refer to this as field change, when you get lots of superficial actinic keratoses over a large area, such as the scalp and backs of hands. On the lower photograph, you can see much more mature actinic keratoses, and as they mature over the years, they can become thicker with a hard, firm, adherent keratin cap. So with sun protection, because these are caused by sun exposure, with sun protection, early lesions might actually resolve. However, without sun protection, they will probably become thicker and more protuberant. Actinic keratoses are, strictly speaking, a pre-malignancy with a very low risk of turning into a squamous cell carcinoma. So the chance of an AK turning into a squamous cell carcinoma is certainly less than 1 in 1,000. How would we recognize that? By the sudden increase in size, of an actinic keratosis, and also with it becoming thickened and indurated at the base. And this would be the symptom and the signs that signify progression to squamous cell carcinoma. So actinic keratoses are both a cosmetic nuisance, they can be tender and sore, and of course they do have a low pre-malignant potential, so they are frequently treated. Obviously, prevention with sun protection is important, and particularly in those individuals who, for example, might have fairer skin, particularly if they're living at altitude and have an outdoor occupation. Protecting the skin from the sunshine with a hat and effective sunscreens is obviously vital. Once present, thinner actinic keratoses can be treated by a number of modalities. So they can be frozen with liquid nitrogen cryotherapy. The hyperkeratosis can be diminished by using things like topical salicylic acid. And then there are a number of other agents that we have to use topically. Topical vitamin A derivatives, such as retinoic acid. Thicker lesions, we use more commonly a topical cytostatic called 5-fluorouracil cream. Again, thicker lesions may not respond to creams and may need to be treated surgically by curettage and cautery. And again, if there's sudden enlargement and a clinical suspicion of the development of a squamous cell carcinoma, it's best, if possible, to excise the lesion for histology. Skin tags are a common nuisance. These are small polypoid lesions. They tend to occur around the lids, on the neck, in the axillae, and in the groins. Pathologically, they may be either small polypoid seborrheic warts, or they may be what we call fibroepithelial polyps. They can become easily traumatized, particularly by jewelry, seat belts, necklaces, collars, etc. So people often desire treatment because they're a nuisance. Skin tags can be treated in the following way. They can be treated by cryotherapy. So what I'm doing in the upper photograph is I've dipped some metal forceps for about 15 seconds into liquid nitrogen to make them cold, and then the skin tag is held to transfer the cold to the skin tag, and it's held in place for about 10 seconds. Over the next 3 or 4 days, the skin tag becomes inflamed, and then with luck will then drop off. An alternative is to submit under local anaesthetic the skin tag to snip cautery. So the skin tag is anaesthetised with some lignocaine, gently snipped off with a pair of scissors, and the base cauterized to stop bleeding. So let's move on to some benign lesions of blood vessels. A common condition which we see relatively acutely is called an eruptive angioma. You may hear them referred to sometimes as pyogenic granulomata. But the word pyogenic granuloma is a complete misnomer because they're neither pyogenic or have a granulomatous histology. A better phrase is an eruptive angioma. So they tend to occur on the finger, the face, and the foot, and often develop after minor injury. And then what happens, you get a rapid proliferation in the production of granulation tissue, which is highly vascular, full of small capillaries. So these lesions grow quite rapidly. So this lesion on the finger has only been there for about 4 to 8 weeks, and they often ooze and bleed with minor trauma. Because they're such a nuisance, patients usually request treatment. But if pyogenic granulomas are left, they will often slowly regress and fibrose. But if possible, we'd excise a pyogenic granuloma. If this isn't possible, they can be submitted to curettage and cautery, but this has a small recurrence rate of about 10%. They often have a surprisingly small stalk, so sometimes if you lift the bulk of the tumour under, you see a tiny little stalk, rather like the stalk of a mushroom. One really important differential diagnosis is that of an amelanotic malignant melanoma. So it is useful to pick the lesion up, have a look underneath to make certain there's no pigmentation, but every lesion which is removed is mandated to be sent off for histology. That's essential. Another exceedingly common vascular lesion is called a cherry angioma. Sometimes they're referred to as Campbell de Morgan spots. So these are almost universal, particularly as people age. Well-defined cherry red spots, very common on the trunk. Easy to recognise. The important thing is to reassure people if they are particularly concerned by them, small lesions can be cauterised. Another benign vascular lesion which occurs in the skin is an angiokeratoma. So these may be solitary, but they're often multiple, occurring on the scrotum and vulva, but they can occur anywhere. They often have a rather lobulated surface. They, on close examination, can appear rather darkly pigmented, but if you look carefully, they tend to be purple in colour rather than black or grey. They may be dark enough to mimic melanoma. Dermoscopy can be a very useful technique for distinguishing these from melanocytic lesions. So they're harmless, but if there's any diagnostic doubt, we would excise them. So looking on to further benign dermal tumours, a very common lesion that we see is called a dermatofibroma. Its synonym is histiocytoma. So these are very common anywhere on the skin, very uncommon on the palms and soles, but can occur just about anywhere else, though very common on the limbs, particularly the lower limbs. Tend to be 5 to 10 millimeters in diameter, and they're firm. They may be solitary or multiple. The central area may appear rather pale with a pigmented outer side. If you palpate these, you'll feel that they're firm. They feel almost like a lentil under the skin. And pinching the skin tends to make the lesion dip down underneath the skin, so we call this a positive pinch sign. Dermatofibromas may be the result of a fibrotic response to minor trauma, particularly things such as insect bites. So if you can make a confident clinical diagnosis, dermatofibromas are often best left, because if they're excised, with them being quite a lot larger under the skin than they are on top of the skin, people often have a relatively large scar. But however, if they're painful, particularly at pressure sites, excision is useful. But it's important to advise the patient the scar may look worse than the actual lesion itself. So it's important to point that out before any progress is made. Lipomas are a very common benign tumour. They're benign tumours of adipocytes. They're firm, rubbery, but one of the cardinal clinical signs is that they feel lobulated. Occasionally they're massive, they can be giant, particularly on the back, up to 10 centimetres in diameter. They may be solitary, however there may be multiple, particularly on the limbs where there's often a family history of multiple lipomata. So what do we do about lipomas? Well, if we can make a confident clinical diagnosis, we can reassure people. If they want the lesions excising, then local anaesthesia can be put underneath the skin. The overlying skin is incised with a scalpel, and the lipoma can be expressed out. Lesions, of course, will be replaced by a scar, but very often people feel this is preferable to the lesion. So let's have a look at one or two other clinical entities. Chondrodermatitis nodularis helicis is a painful condition which tends to occur on the ear in the older age group, and it tends to occur on the most lateral part of the ear. It's due to pressure of the ear against the pillow when people are sleeping. And it tends to occur on the ear that spends most of the night against the pillow. So if people predominantly sleep on their left side, they often end up with left ear chondrodermatitis. So in the upper panel, you can see the most common site where it occurs on the upper part of the helix. In the lower photograph, you can see because the ear is slightly more swept back, the pressure site is on the antihelix. So that's where the area of chondrodermatitis has developed. But the clue is they are painful and tend to occur on the most lateral, as it were, weight-bearing area of the ear. Chondrodermatitis can be treated by minimizing the pressure that occurs on the ear by using a special a cushion which is designed to take the pressure on the skull rather than on the pressure area of the ear. The painful area can be treated by intralesional steroid injections, and sometimes that will affect their resolution and pain relief. If problems persist, then the area can be excised, but it's important to remove the cartilage underneath the nodule so that the pressure that's causing the problem is relieved. So these occur due to the pressure of the cartilage against the skin, against the pillow at night time. So by flattening down the cartilage, the condition will often regress. Moving on to nevi. Nevi are benign proliferations of one or more normal components of the skin. They may be present at birth, or congenital, or acquired. Examples of the tissues that might be involved in these benign proliferations include melanocytes, vascular lesions, epidermal components, and connective tissue. Melanocytic nevi, otherwise called colloquially moles, are universal. Only 1% of us are actually born with a congenital nevus, although we almost all develop acquired nevi. An average woman at 40 has 40 moles. An average man at 40 has about 30. Moles will develop, mature, but some will also regress. Melanocytic nevi develop due to the migration of melanocytes from the neural crest towards the epidermis during embryonic life. Melanocytes produce melanin, therefore they pigment. The position of the melanin within the skin to a degree will determine the colour of the lesion. So melanin within the epidermis or at the dermoepidermal junction will appear black or brown, whereas deeper melanin pigmentation within the dermis appears blue. So here are some examples of melanocytic nevi. Both of these are congenital nevi which were present at birth. Congenital melanocytic nevi will vary in size from small, they may be as small as 5 or 6 millimeters, but may be large where they may cover big areas of the body, and they're often referred to as cape nevi or bathing trunk nevi according to their position. They're usually dark at birth, but during maturation as children become older, they may become darker, rougher, and hairy. We almost all develop acquired nevi, and we develop these from childhood through till about the age of 40 or 50. Acquired nevi tend not to develop after this age. They may occur at the dermoepidermal junction, where they tend to be flat, round or oval, macular, and dark brown to black. Nevi within the dermis are often dome-shaped. They may be brown initially, but as they mature, they often lose their pigmentation and become flesh-coloured, particularly on the face, and they may be hairy. Compound nevi affect both the dermis and epidermis. They tend to be smooth, brown, and less than 10 millimeters in diameter. In the upper picture, we see an example of a junctional nevus. It's just palpable, flat, tan to dark brown in colour. It's regular in its outline and regular in its pigmentation. There's no notching to the edge. The lower image shows a compound nevus, which as it's matured has become slightly rough and warty or verrucous. Here are some examples of some compound nevi, which as they've matured, they've lost their pigmentation, become dome-shaped, flesh-coloured and protuberant, and they're sometimes termed cellular nevi. Here's an example of a particular subtype of melanocytic nevus called a Spitz nevus. They often start in childhood, can occur anywhere, but the face is quite a common sight. They're often red to brown in colour, and as they mature, they tend to become browner. They may arise quickly and cause alarm. The histology shows spindle-shaped melanocytes, and the histology may mimic malignant melanoma, although Spitz nevi are completely benign. So it's an important consideration to be given this particular special variant of melanocytic nevus called Spitz nevus. Here's an example of a relatively common variant of melanocytic nevus called a blue nevus. And this is due to the fact that the melanocytes are relatively deep in the dermis, and because of the optical properties of the skin, it gives the lesion a blue colour. So they often are slaty or steel blue. This is an example of a particular type of acquired melanocytic nevus called a Sutton or halo nevus. And what happens here is that surrounding an entirely benign appearing nevus, there develops an area of depigmentation. And what may happen is, over the months to years, the mole within this area of depigmentation may regress. Halo nevi may be solitary or multiple, and people who get a halo nevi are at greater risk of developing the skin condition vitiligo. So how do we approach the management of benign moles? Well, the indications for removing a mole would be if there is the suspicion of malignant change, and these features will be covered in detail in the lecture on skin cancers and melanoma. So if there's a suspicion of melanoma, the lesion would need to be excised. Nevi, particularly if they're protuberant, can be traumatized by collars and underwear, and that makes them sore and an inconvenience. So that might be an indication for removal. Mole removal is sometimes desired for cosmetic reasons, and of course we've got to balance the cosmetic effect of removing the mole versus the resultant scar. Occasionally moles, particularly if they're hairy, will develop within them recurrent folliculitis, and that is sometimes an indication for removal to prevent this occurring. So if there is a suspicion of a benign mole transforming into a malignant melanoma, they would be excised, and in the upper panel you can see excision being undertaken with an elliptical area of skin removed and then sutured back together. In the lower panel, you can see somebody who's got a cellular nevus, which is catching when he shaves. And this is being submitted to shave excision. So what happens here is local anaesthetic is administered underneath the lesion. As soon as it's anaesthetised, the scalpel is used to shave the mole flush with the skin, and the bleeding is stopped with cautery. The area will heal within a week or so with a very good cosmetic result. Nevi can occur from epidermal components, and obviously these are called epidermal nevi. They're very often linear or tick-shaped because they follow what are called the lines of Blaschko. So in people with paler skin, they're often pink-brown, and over the years they can become more warty and verrucous. Rarely, epidermal nevi occur all over the body, and this is called a systematized epidermal nevus, and they may be associated with some internal problems as well. A fairly common nevus that we see, usually on the chest unilaterally, is called a Becker's nevus. And this is a flat epidermal nevus, which at first may be pigmented, but as time goes on, and usually at around puberty, the area will develop hypertrichosis. So you can see that in this lesion here, there's more hair on the right side of the chest within the nevus than there is on the left. So this is a kind of epidermal nevus which will be pigmented and macular at first, and later on will develop hypertrichosis.